All right. Good morning, everyone. I hope everyone had a great night in Honolulu last night. So this morning, we're going to kick off the meeting with the abstract presentation. I think we have about 22 abstracts this year, and it's divided up into 4 sessions. After each session, we'll have about 5 to 10 minutes discussion time. And then each abstract will be scored by our judges, including our honor speakers and senior faculty here. And based on basically content, delivery, and clinical impact and originality of the research. Each category is 1 to 5 points. The higher points you get, the better it is. And then at the end, we'll tally it. We'll have top 3 abstract will have a trophy, and then some surprise prize we'll present later. So without further ado, the first session include 6 abstracts. The first one is by Alexa, one of our residents. She'll present on agreement and the relation, reliability analysis on sarcopenia. So go ahead.
All right, good morning. My name is Alexa Samanchi, and I'm going to be presenting work that I did with Dr. Ames and the UCSF Spine faculty on agreement and reliability analysis of sarcopenia measures in adult spinal deformity patients. I don't have any disclosures. Mechanical failure such as proximal junctional kyphosis remains a major issue in spinal deformity surgery. Despite what radiographic alignment target you use, such as the SRS Schwab or the Rusoli classification system, even though they become increasingly complex, the rate of mechanical complication essentially remains unchanged. One problem is that these alignment goals are only based on static radiographic parameters measured on a single standing scoliosis film. This ignores the contribution of dynamic motion in the musculoskeletal sheath surrounding the instrumentation. My research focuses on the impact of sarcopenia on spinal deformity outcomes. Sarcopenia is defined as a global degeneration in skeletal muscle strength, quality, or quantity. I'm sure you can tell that compared to the left, the muscle quality on the image of the right is atrophic and infiltrated with fat. That is sarcopenia. Does sarcopenia impact surgical outcomes? The research is mixed right now. The problem is that how sarcopenia is defined and quantified across studies varies widely. In this study, we asked patients to undergo 7 sarcopenia measures that are commonly referenced in the literature during their preoperative clinic visit. These included 2 functional measurements, grip strength and gait speed. We also used bioelectrical impedance studies, which shoots an electrical current through the body to measure body composition. This gave us 3 measures, the skeletal muscle index, or SMI, the ratio of total body water to extracellular body water, and the phase angle. And then finally, we use CT imaging to look at the psoas muscle, and we derive 2 measures from this. The psoas muscle index, which is a cross-sectional area divided by height of the patient, or the TPA over VBA, which is the total psoas area over the vertebral body area at L3. Here are the results of the sarcopenia measures based on sex. As you might expect, men generally had higher median measures than women. In a previous study that was not shown here, we found that most of these sarcopenia measures are correlated with each other to a statistically significant degree, but all of the correlation coefficients are weak to moderate. So for this study, we decided to look at a more rigorous set of statistical testing to ask whether these measures are generally interchangeable, i.e., are they measuring the same fundamental underlying clinical entity? The first test we used is called Bland-Altman analysis. In this test, it measures, the takeaway is that the wider the margins of the blue bars, the less these measures agree with each other. So on the left, you see extracellular water over total body water and phase angle. There's very little agreement between those measures. Whereas for PMI and TPA over VBA, that had the highest degree of agreement because the limits of agreement are more narrow. And we did this for all 21 pairwise measures between our 7 sarcopenia measures. Overall, we found poor agreement in between every measure compared. We also did Cronbach and reliability analysis, and we also found that in general, there's low reliability between sarcopenia measures. Again, the two imaging-based measures had the highest degree of reliability among all the pairs tested, probably because they have the same numerator. They all look at total psoas muscle area divided by a different denominator. So in general, there's poor agreement and reliability between commonly used sarcopenia measures currently cited in the literature. So there's a need to identify which sarcopenia measures, if any, are salient to spinal deformity outcomes. Currently, we think the literature is mixed because people do not agree on how to define, quantify, or diagnose sarcopenia. All right, thank you.
All right. Our next speaker is Dr. Alekos Theologius. He's going to talk on construct rail technique for decreasing screw strain across the thoracic VCR site.
Thanks, Lee. The only disclosure for this is this study was funded by Globus. So by way of background, 3-column osteotomies are common in the thoracic spine, and they're powerful techniques to correct a variety of deformities. The major corrective techniques used include segmental compression and cantilever bending to increase the anterior column length, but also shorten the posterior column. Both cantilever bending and segmental compression place significant stress on the screws, especially around 3-column osteotomies. This can result in screw pullout and screw plow, which can jeopardize deformity correction, and particularly in patients with poor bone quality. So the question is there a safer alternative? And I propose there is. It's called the rail technique. And this involves placing a lateral accessory rod above, short rods above and below the construct. And you can perform segmental compression directly on this lateral accessory rod as shown in the upper right. But you also can perform cantilever bending also through this rod. I've written several papers demonstrating the clinical efficacy and safety, and recently also performed a mechanical analysis. But the purpose of this study was to do an in vivo biomechanical analysis to compare screw strains above and below a 3-column osteotomy, both during segmental compression and cantilever bending, comparing traditional methods and the rail technique. So we took 8 cadaveric specimens. We performed T8 VCRs, induced about 25 degrees of kyphosis. We did 3 levels above and 3 levels below of instrumentation. 4 screws, the 2 screws above and below were instrumented with strain gauges, as you can see on the bottom right, which would measure screw strains during dynamic compression as well as the cantilever bending. Both deformity corrective maneuvers, so compression was performed using the rail technique you see on the upper left, and through the traditional method through the midline rod. This also was performed with cantilever bending via the rail technique and the traditional midline rod. Real-time screw strains were collected and peak strains were compared between the corrective techniques. So in terms of results, segmental compression found that the maximum screw strains were significantly lower during the rail segmental compression compared to traditional. You can see in the peri VCR screw at T7 and one above that the traditional screw strains are considerably higher in the black boxes there. Also, screw strain was more evenly distributed across all 4 instrumented screws during rail compression compared to traditional segmental compression, in which the screw strain was most focused on the peri VCR screw. For cantilever bending, similar results were found. Maximum screw strains were significantly lower during the rail cantilever bending compared to traditional, and the total screw strains were more evenly distributed across all the screws. So in conclusion, performing segmental compression and cantilever bending across a lateral accessory rod, which we call the rail technique, resulted in significantly lower strain on individual pedicle screws adjacent to a thoracic VCR compared to traditional techniques. This may lessen the risk of screw pullout as well as screw plow during maneuvers to correct spinal deformities across a 3-column osteotomy. Thank you.
All right, our next abstract is by Dr. Austin Katz on the effect of cement augmentation on reoperation rate in spinal deformity surgery.
All right, good morning. I'm Austin Katz. This is my project looking at cement augmentation and reoperation rates, and we have no relevant disclosures. Cement augmentation has been used to enhance construct stability in long spinal fusions, particularly for adult deformity surgery. It has been used to prevent screw pull-out in osteoporotic bone, as well as to prevent PJK. However, cement extravasation into segmental arteries can theoretically diminish vertebral body blood supply, potentially increasing the risk of vertebral body failure and subsequent need for reoperation. So using a large national database, the study evaluated the impact of cement augmentation on reoperation rates following deformity surgery with fusion to the pelvis. The Pearl Diver database was queried for patients undergoing long construct fusions to the pelvis from 2010 to 2021, utilizing the shown CPT codes. Patients were split into cemented and non-cemented cohorts based on their presence or absence of vertebroplasty and kyphoplasty codes, respectively. Cohorts were compared on the basis of reoperation and postoperative complications. Multivariate regression, adjusting for demographic and comorbidity variables was utilized. So baseline differences revealed that patients with cement augmentation were almost 10 years older on average, were more likely to be female, and had significantly greater rates of numerous medical comorbidities at baseline. In univariate analysis, patients with cement augmentation had greater rates of 90-plus day reoperation and up to 90-day rates of pulmonary embolism and UTI. Specifically looking at reasons for reoperation, so amongst the cases that had reoperation, there was a significantly greater proportion of reoperation cases occurring specifically for device reinsertion CPT codes in patients without cement compared to patients with cement. Multivariate regression analysis found cement augmentation to be a significant predictor of 90-plus day reoperation, but not for pulmonary embolism or UTI. So in conclusion, our study found that patients undergoing long construct fusion to the pelvis had greater rates of long-term reoperation, pulmonary embolism, and UTI. After adjusting for significant patient factors, cement augmentation remained a significant predictor for long-term reoperation, but not for pulmonary embolism or UTI. The granularity of the Pearl Diver database isn't really great enough to specifically hypothesize on why cement augmentation was a significant predictor for reoperation. Patients receiving cement augmentation were considerably less healthy at baseline, with a number of surrogate variables consistent with poor bone quality for that cohort, which itself is a known major risk factor for construct failure. Based on the reasons for reoperation table data, it seemed that cement augmentation did help prevent screw pull-out, but caution should definitely be taken when attempting to interpret reasons for reoperation based on ICD and CPT data alone. Further research should focus on vertebral body bone analysis after cementation to make conclusions about blood supply compromise as a potential risk factor for PJK following cement augmentation. Thank you.
Our next speaker is Dr. AJ Aga on percutaneous posterior S1 to ALM spinal pelvic fixation.
Hi, everyone. Thanks, everyone, for giving me the opportunity to present our project, limiting the cranial extent of spinal pelvic fixation to S1, select posterior pelvic ring injuries, and lumbosacral dissociations. No relevant disclosures. To start with some background, pelvic ring injuries are among very common ones that we see in the orthopedic trauma world. And they have variable described patterns, as you can see up here, but we usually think of these as falling into two main categories. The first of which is our vertically oriented patterns, which traditionally fix with iliosacral and transiliac transsacral screws. However, these constructs are port-resisting shear forces, and we often have to limit our post-operative weight bearing for a few months after the surgery. The other injury pattern that we see is our lumbosacral associations, the transverse component. And these are traditionally fixed with spine-based lumbosacral fixation, with or without instrumentation or fusion. But the downside here is that you limit the lumbosacral motion, which is significant for many of these patients who are often younger, that require hardware removal at a later date if fusion was not indicated. And so if we utilize spinal pelvic fixation limited just to S1, then in vertically oriented patterns, we can allow for immediate weight bearing, as this would resist heavy pelvic flexion, and often we only need to do this unilaterally. And then in select patterns where the S1 pedicle is intact, we can avoid spanning the mobile segment, and then we can avoid the need for secondary removal of hardware later on down the road. And so in this study, we performed a retrospective review of all patients undergoing spinal pelvic fixation at the academic center and then at UCSF. And for all these patients who underwent posterior spinal pelvic fixation, limited to S1 between 2022 and 2025. We collected demographic data, fracture pattern, surgical fixation details, weight-bearing restrictions, ambulatory status at DC, follow-up duration, as well as any needs for reoperation. And so here's our slide of our data. There were 9 patients identified in total. Percutaneous fixation was done, all of them at S1 to the ilium. There were 7 females and 2 males, an average age of 50. There were 6 orally oriented patterns, as you can see in blue, and 3 lumbosacral dissociations with minimal to moderate kyphosis with intact S1 pedicles. Average follow-up was 227 days with a range of 4 to about 700 days. And no weight-bearing restrictions were for the pelvis specifically, but 2 patients with separate periarticular lower extremity fractures did have a weight-bearing restricted to that side of the injury. As you can see, all but 2 patients were ambulatory at discharge, and there were no hardware failures. But 1 patient did undergo hardware removal for significant weight loss after GI pathology, in which he lost about 50 or 80 pounds, I should say. And so here's just a quick case example. We have a 30-year-old woman here with multiple social risk factors. She presented with pain-limited ambulation. She was neurologically intact and was found to have a U-type sacral fracture with about 37 degrees of kyphosis. So she underwent percutaneous reduction with an external fixator pins that were placed in the S1 and the ilium, and then these are manipulated with a lower dose of force to essentially reverse some of that kyphosis. The reduction was then held in place with X-fix bars and clamps, and this allowed us to place our transiliac transsacral screw with the sacrum in a reduced position. And as you can see here, we're placing the screw, and then this was essentially used to keep our fixation, and then we exchanged all the stance pins and placed the pedicle screws in traditional spinal fixation. So here is her post-op imaging. You can see her kyphosis improved to about 17 degrees, about a 20-degree change overall. The patient was made weight-bearing as tolerated by day of discharge and was ambulating 150 feet with a walker. So in conclusion, this is a small series. And we like to demonstrate that we could see essentially do percutaneous fixation from S1 to ilium was feasible. It allowed quick weight bearing and unstable vertical patterns. And we did spare the lumbosacral junction with its lumbosacral dissociations and required moderate reduction. And so this is a feasible technique that we'd like to present to all of you. So thank you so much for hearing.
All right. Our next speaker is Dr. Richard Menger. He's going to present on clinical outcome using screw fusion implant for SI joint in the setting of adult deformity.
Awesome. Good morning. So I'll present the results from the Paula trial, a multi-center prospective study looking at actually fusing the sacroiliac joint in the setting of spinal deformity. So disclosures funded by SI Bone. So when we talk about fusing the sacroiliac joint in the setting of spinal deformity, we're tackling 2 problems that are clinically relevant. So the first is, as you have a lumbar fusion and you increase stiffness, especially at the junction, you increase the biomechanical forces or the stress on the sacroiliac joint. So the higher up that fusion goes, the more stress is dissipated onto the sacroiliac joint. The other is, we've sort of seen that evolution, over the years, is the concept of getting robust pelvic instrumentation. Right, so stopping at S1, right, then we move to the iliac screw, then S2 alar iliac screw. This is a different modification of that. We're actually fusing the sacroiliac joint, right? And the goal of that is to protect screw loosening, right, to prevent distal construct failure, to protect the L5 S1 and reduce our reoperation rates. So, what is this screw? So, again, this is different than your traditional iliac or S2 alar iliac screw. So it's a porous surface with self-harvesting for bony overgrowth. So the idea is for bone to grow through there, and having to have to take these out for different reasons, you can absolutely see the bone grow through that screw interface. So again, the goal is fusing the sacroiliac joint. All right, so the Paula study, and again, I'm speaking on behalf of multiple centers collecting data for this. So single-arm, multi-center trial, there's prospective and retrospective. 400 participants, and looking, and what we're discussing here today is, hey, what are our early outcomes, right? So there's a lot of data looking at this and looking and comparing what are the early biomechanical failures in the setting of instrumentation of the pelvis, kind of building on Dr. Polly's series. So we said, hey, what are we looking for? L5S1 pseudoarthrosis, distal rod fracture, set screw dissociation,
implant loosening and screw breakages, all the problems that we see in our clinical practice. Right. Who are these patients, right? Well, they're our typical adult deformity patients, right? So they're in their 60s. 2/3 of them had surgery before. Their BMI is a little bit higher, right? And it goes through, again, most of these are more than 5-level surgeries. These are bigger deformity surgeries, right? So again, this is early biomechanical problems. That's what we're presenting here and looking at today, right? So, having one set screw dissociation in that process, right? So this is actually my case. This is a gentleman, he's 56, high BMI, diabetic, has his instrumentation removed, pretty, robust sagittal plane deformity, corrects when he's lying down. This is his initial instrumentation and X-ray. I went short because I thought it was a little bit more forgiving and flexible, and he was high medical comorbidities. You can see the rod pull out and the breakage, right? So we looked at the retrospective series, again, some distal rod fractures, looking at, through the different, outcomes in different places. So to kind of finish up, right, our interim results are very positive for early instrumentation failures, right? We compare that to the 2 leading series on these from 2022, right? Dr. Martin, Dr. Polly's series, looking at this, having one true, real early failure. So the idea is that protecting the sacroiliac joint will help reduce operation for these patients. So I appreciate the opportunity. Thank you.
Last talk for this session is Dr. Asra Tube Beyond Cement, identifying the drivers for junctional failure.
Good morning. Okay, I have no financial relationships to disclose. Proximal, we have already talked about it a lot. Proximal junctional failure is a significant complication of adult spine deformity surgeries. And we know that cement augmentation, either UIV, UIV+1, or both, is commonly used to reduce this risk. Previously, it was shown in our group that 2-level cement augmentation could reduce PJF revision risk significantly. But is cementing enough? We still see patients with long thoracolumbar spine fusion with PJF. So the purpose of this study was to evaluate the frequency of PJF in long thoracolumbar spine fusion constructs who had cement augmentation at UIV, UIV+1, or both. And also we tried to identify other contributors to PJF. We retrospectively reviewed adult patients who were treated at University of California, San Francisco. All constructs included cement augmentation at UIV, UIV+1, or both. We identified patients who developed PJF and didn't develop PJF at 6 months mark or 1-year follow-up. And we compared between the 2 groups, the demographic, surgical techniques and construct, pre-op and post-op radiographic variables. Overall, 89 patients were included in the study, and 12 of them developed PJF. There was no difference in age, gender, or BMI. There was also no difference in cement level, rod material, UIV level, pre-op or post-op global alignment parameters. However, in PJF group, there was a significant post-operative, PJF patients had significantly larger post-op kyphosis. Also at the thoracolumbar junction, T10 to T12 kyphosis was significantly larger in PJF group. Post-op UIV+1, UIV -1 angle was significantly larger in PJF group. And when we compared the change from pre-op to post-op thoracic kyphosis, the change was larger in PJF group. And finally, accessory rod distance to UIV was significantly smaller in PJF group. In our multivariate analysis, only post-op T10 to T12 kyphosis was an independent predictor for PJF. Accessory rod distance to UIV was only borderline significant. In conclusion, UIV, UIV+1, or both cement augmentation alone do not prevent PJF. In our study, global alignment did not influence PJF risk, but more so thoracic alignment and construct design were more predictive of PJF. Overall conclusion, even in cemented construct, we still have to pay attention to biomechanical alignment and construct design as a way of preventing PJF. We acknowledge that the sample size was small, and we're hoping to have larger sample size or more prospective studies to validate the findings. Thank you.
So we have a few minutes for questions. Any questions from audience? I have a question for Dr. Menger. For the study, did all the patients get 4 rod screws across the outside joint, 2 on each side, or are there single screws cases as well?
Yeah, great question, Lee. I think there's definitely some heterogeneity in how much instrumentation is in the pelvis. Most are, 2 points of pelvic fixation, but as the study sort of went on in the retrospective part, it moved more to 4 points of fixation. And I think the other part of that is the closed-headed screw also wasn't sort of the first release, or the open-headed screw was primarily in the earlier parts of the study, and then later the closed-headed. So there's definitely some difference in some of the nuances retrospectively.
How about the rod type? I mean, that's the screw is one thing, but then, is it titanium or cobalt chrome or 6055? Is it kind of up to the surgeon, or is it?
Yeah, so it's up to the surgeon. That stuff is captured and sort of looked at. This, the initial reporting from the early biomechanical failure, we didn't kind of focus on that aspect, but it is tracked when we do this the cases.
For Alekos. Thanks for your talk, Alekos. What was the traditional method that you described? Because I didn't see it as clearly defined what traditional was. And then 2, did you look at other methods besides traditional, like a central rod technique and some other things that have been described?
Great question. Thanks for the opportunity to clarify. So the traditional method for segmental compression was putting a rod, say a temporary stabilizing rod, across the VCR site, spanning all screws, taking a rod holder at the VCR site, tightening the bottom screws, loosening the proximal screws, and then compressing from the rod holder to the screw right above. That's segmental compression. Cantilever bending was under contouring the rod, fixating it distally on the 3 screws, and then pushing it down into the proximal screws. We did not look at any other techniques, but I think that would be a nice thing to do.
Alekos, I have one question about the cantilever bending technique. When I think about that, I have some concern that when you lock it in proximally and distally, and then you do the cantilever bend, does that extend the anterior column and potentially loosen the cage you put in? Because the axis of rotation is really so far dorsal.
Yeah, that's a great question. So if your anterior column in a real VCR is removed, then yeah, that can happen. So you need to be careful about the cage becoming loose, but if you are trying to correct kyphotic deformity, good that the anterior column lengthens, but subsequently you then need to expand your cage to fill the anterior column. And it's a combination of, shortening the posterior, lengthening the anterior, shortening the posterior. It can be multiple sequential rod exchanges to ultimately get the correction that you want.
So a question for speaker 1. So sarcopenia is a serious problem for the deformities, but sometimes even for the degeneratives. So in your study, you didn't find any better measures to assess the sarcopenia, but in your clinical practice, how do you follow patients before and after surgery, even they suffer the sarcopenia? You have to see something. So what do you recommend to do that?
I think there are a few interesting studies coming out from groups now that are doing a pre-surgical rehabilitation program. So they offer patients 6 weeks of intensive physical therapy to try to improve their muscle strength and function before surgery. There's a group in Toronto that published that they actually saw an improvement in surgical outcomes after that intensive therapy. The weaknesses of that study are that it was an entirely voluntary protocol. So these patients were probably more motivated to work on their muscle strength beforehand. It was not a randomized control trial. And then I think to your point, when we, in Dr. Ames's clinic, we measured all of these sarcopenia measures preoperatively, and then we also measured them at 6 weeks, 3 months, 6 months, a year, and 2 years postoperatively. As the cohort MAT progresses towards a 2-year endpoint, we are going to be able to look back at their preoperative data and see which sarcopenia measure was the most relevant. Is it functional assessment, body composition, or their imaging quality? Even though imaging is the most commonly utilized sarcopenia measure, I think the weaknesses of that are that once you put in instrumentation, it's almost impossible to compare sarcopenia post-instrumentation and pre-instrumentation. So I think we are going to have to find a functional or another way of measuring sarcopenia that allows for that kind of comparison.
Okay, thank you.
Lee, can I ask one of the cement papers? So for both Austin and Astra, as you're about to enter your own practices here next month, what's the take-home message? What are you going to be doing in your practices at the UIV for cement, or the UIV +1 for Boston?
I think, for patients that have really poor bone quality, there is data to support that cementation is beneficial. I think it needs to be an individualized decision based on patient bone quality ultimately. If I were to cement at the UIV, I would extend to UIV +1. I believe I recall coming across some data that shows that you're only doing the UIV. There is an increased risk of failure.
I agree with Austin that in osteoporotic bone, I will definitely cement the UIV +1, knowing that they have risk associated with that as well. It's not completely benign. But based on the study that I just did, even though the sample size was small, I still saw improvement, decreased risk of PJF in UIV +1. All our patients had UIV +1 cementation.
Yeah, I think another thing to consider too is the technique of how you're doing the UIV +1. If you're disrupting more soft tissue to get to that level, that itself is also a risk factor for PJK. Whereas if you're percutaneously doing it, that may be protective.
All right, great. So in the interest of time, we'll move on to the second session.
Shift gears to some pediatric topics. First up is Dr. Kelsey Hideshima. We'll talk on the pediatric spinal trauma management clinical outcomes.
Okay. So I'd like to thank Dr. Roberto and the rest of the UC Davis spine faculty and our pediatric surgery department for their support in this project. We looked at pediatric spinal injuries over a 15-year period. Let's see. So traumatic spinal injuries in the pediatric population, although less common than in the adult population, can have life-altering consequences. And the primary trauma assessments between the adult and the pediatric populations are nearly identical, but where they diverge is in the secondary assessment and the desire to balance the need for reduced advanced imaging and to reduce the amount of missed injuries in children. And so there's a potential for missed injuries in the pediatric population. The goal of our study was to analyze a large sample of pediatric trauma patients at our center and to classify their injuries and their associated injuries to further understand the different types of injuries that these patients can have. So it was a retrospective study including all patients under the age of 18 from 2009 to 2024 with at least one or more spinal and neurologic injury. In our study cohort, we had 891 patients included. The average age was 10. We had a mortality rate of 4.4%, an average neurologic injury of 26%. 18% of the patients required spinal surgical intervention, and 41% of patients were in-facility transfers. We did look at a couple of socioeconomic factors, like the Child Opportunity Index and the Area Deprivation Index. And one thing that we found interesting was this dichotomous relationship with the Child Opportunity Index in our patient population, with 38% of them coming from the very low categories and 35% coming from this very high category. When looking at mechanism of injury across all age groups, the most common was motor vehicle accidents, not surprising. In terms of sports-related injuries, this is most commonly the school age and teenage children between football and horseback riding. Looking at assault, we had 4% of our patient population having firearm injuries, and these were all within the teenage category. When looking at associated injuries in this patient population, the most common associated body region was the chest. And then in addition to the 18% of patients needing spinal surgical intervention, nearly 1/3 of the patients required critical care procedures as well. We classified the different spinal injuries using the AO Spine Injury Classification System, and the most common surgical spinal region was the thoracolumbar region, specifically A0 and B2 subtypes, and then the second most common was the subaxial cervical region, again with the similar subtypes of A0 and B2. And then looking at our surgical data, about 10% of the cases were done percutaneously, 25% were done with navigation, and about 50% were done using some sort of direct decompression. And then 65% of our patients at their final follow-up had improved neurologic exam. So overall, the suspicion for spinal injuries and the pediatric trauma encounter should be high, especially in the cases of motor vehicle accidents and impact, with 1/3 of the patients having concomitant surgical injuries that necessitated critical care intervention, and a large amount of these patients having neurologic injuries. There's a need for these patients to be in a pediatric critical care environment, wherein spinal cord perfusion management and interventions such as pressors and cytoprotective pharmacologic agents can be administered safely. Looking at our AO classification, many of these injuries were ligamentous in nature and may have been missed on initial imaging, stressing the importance of advanced imaging protocols. And then lastly, there's a wide geographic diversity and dichotomy with respects to Child Opportunity Index, reflecting potential disparities in pre-hospital triaging, transport, and access to care, which just makes further research necessary to make sure we're providing more equitable care into these regions. Thank you.
Next up is Dr. William Marmer, who'll speak on anterior vertebral tethering and pediatric scoliosis.
Hey, good morning, everyone. My name is Will Marmore from University of Miami. I'm a PGY4. I'm presenting on vertebral tethering and pediatric scoliosis. This is an analysis of 335 patients, and we compared it to posterior spinal fusion. I have no disclosures to discuss. So tethering is an emerging motion-preserving option for adolescent idiopathic scoliosis. And the aim of the study was to analyze several different characteristics in tethering compared to posterior spinal fusion. And so we looked at patient demographics, we looked at hospital characteristics, and then we also looked at perioperative outcomes. So here's an image from Boston Children's comparing tethering versus posterior spinal fusion. And really the aim of tethering is to provide correction and deformity without fusing the posterior column of the spine. So essentially providing correction, but enabling more mobility. So we looked at the 2022 Kids Inpatient Database. It's a large national database. And we looked at both thoracic and lumbar tethering and open versus percutaneous, and we compared those to posterior spinal fusion. And so the outcomes we looked at were demographics for patients. We looked at hospital characteristics, including the region, whether or not the hospital was academic, the bed size, ownership, and then importantly, we looked at length of stay as well as total hospital charges for our patient populations. So we collected about 335 tethering patients, and we compared that to about 10 times the number of posterior spinal fusion patients. And what we found was that the tethering patients were overall younger. They were more likely Caucasian, and they came from privately insured backgrounds and higher income areas. The hospitals that these are being performed at are large urban teaching hospitals, mostly in the Northeast. And so in terms of some of the outcomes, overall tethering had a much lower length of stay compared to posterior spinal fusion. Patients are staying about 3.6 days versus 6.1. There are, however, though, much higher hospital charges, about $317,000 for tethering versus $277,000 for posterior spinal fusion. And patients who underwent tethering were more likely to be discharged to home versus to a rehab facility. So overall, tethering is often performed in wealthier, predominantly Caucasian populations. It's associated with higher hospital charges right now, but it may enable a lower length of stay in a hospital. So if the charges for tethering decrease over time, it might provide patients a mobility preserving strategy for scoliosis. Thank you.
Next is Dr. Mohammed. I guess we can see if here or not. We'll go, just in the interest of time, we'll move on to Dr. Ramon Brown. We'll speak on the impact of sex and pelvic anatomy on S2AI screw placement.
Hello, everyone. Thank you for having me. So my name is Ramon Brown. I'm coming to you all from Mount Sinai. So this is some work that we did with Dr. Lin, looking at how S2AI screw positioning can be impacted by biological sex. We have no disclosures. So we know that S2AI screws are often used in multi-level ASD constructs. It's no secret that there's sexual dimorphism in humans, and so the male pelvis tends to be more narrow than the female pelvis. What this leads to is anatomically, that means that when we're going to put the S2AI screw in, they tend to be more medial as opposed to the female's screws where they tend to be more lateral. So that necessitates bending of the rods, which can impact the overall balance of the construct and the coronal plane. So for this study, we kind of wanted to put some numbers on this and see. So we took several measurements. The first was inter-PSIS distance, which we kind of use as a proxy for the differences in the pelvises between males and females. We also did rod-to-rod angle, and so literally looking at how parallel or convex the rods were. And then S2AI to SAI screw distance. So again, just seeing what the difference between the two screw heads is. The two screw heads were when we put them in. So there were 185 complete cases. The majority of them were female, about 68%. 154 cases were performed freehand, while 31 were performed stereotactically. And so there was about a difference, statistically significant difference between the females. They did exhibit a greater PSIS distance as we would expect. The average rod-to-rod angles were also statistically significant at negative 12.3 in males, and in females it was 7.6. The PSIS distance was also a strong predictor of both rod-to-rod angle as well as screw distances. So the discussions, it's again, things that we know to be true, but we wanted to put numbers on it quantitatively. The male pelvis tends to be more narrow, leading to a more medial screw placement. As a result, males exhibit greater distal rod convergence and less parallel rod alignment across that lumbosacral junction. So for us, what this looks like, obviously, is tailored surgical strategies between males and females who may need it to be able to optimize the lumbosacral rod alignment. So why should spine surgeon cares? And so obviously, this means that there's a need for careful pre-op planning and considering tailored surgical strategies to accommodate for these sex-based differences. Obviously, this is a quantitative study. We don't know what this means qualitatively in terms of outcomes, so that's what future directions would be. Thank you.
And I think to close out this session, Dr. Lisa Bonsinor-Opp, validation of an injury, severity score in pediatric thoracolumbar trauma.
Great. Yeah. Hi, my name is Lisa Bonsinor-Opp. I'm a fourth-year resident from UCSF applying into PEDS and spine fellowships. Our study is validation of injury severity score in pediatric thoracolumbar trauma. We have nothing to disclose. So in adults, both the TLIX and AO spine scoring systems have been successfully used to recommend operative versus non-operative management based on fracture morphology as shown here from the AO spine classification system, neurologic status, and the integrity of the PLC. However, these systems currently have unclear applicability to the pediatric population. So the purpose of this study is to assess the relative validity of these two systems during skeletal maturation. So we conducted a retrospective review of prospectively collected data from a single academic institution, including pediatric patients with thoracolumbar fractures from 2012 to 2018. Skeletal maturity was assessed by risser and triradiate cartilage closure. So validity was then analyzed based on operative management using accuracy, sensitivity, specificity, positive predictive value, and negative predictive value. Cases considered borderline operative based on the scoring criteria, so TLIX 4 and AO 4 or 5, were excluded from the validity analysis. So we identified 197 pediatric trauma patients for the review, and 87 were included in the final analysis. The average age at injury was 10 plus minus 4 years, and of the patients with available skeletal maturity data, 45 had open triradiate cartilage while 24 were closed. So the mechanism of injury also varied significantly based on skeletal maturity. Patients with open triradiate cartilage in that younger category were more commonly injured by falling, where more skeletally mature patients were more injured by motor vehicle collisions. So the rate of operative intervention overall was 11.5%, and that's shown at the top there in red. At minimum, all these patients received a posterior spinal instrumentation infusion, and there were no significant complications. The actual rate of operative intervention, so that red box, varied from the rate of operative intervention suggested by both scoring criteria, with the TLIX there in green and AO spine in purple. So in the overall study population, the TLIX and AO spine performed pretty similarly. So when looking at this, but then when looking at the subgroup of patients with open triradiate cartilage, both scores had relatively higher false positive rates, meaning that more patients were indicated for surgery based on the score than those that actually underwent surgery. For TLIX, all false positive patients sustained flexion distraction injuries, while for AO spine, one false positive patient had a complete burst fracture, while the remainder sustained flexion distraction injuries. So both the TLIX and AO spine had 100% sensitivity and negative predictive value throughout skeletal maturity. This is suggesting that the adult scores may be accurately used to indicate patients for non-operative management. But in patients with open triradiate cartilage, both scores performed poorly for positive predictive value, suggesting that these classifications are not predictive or suggestive of patients who need to undergo surgical management. So both scores particularly struggled with appropriately recommending management for flexion distraction type injuries. So in summary, this is the first study to validate the adult thoracolumbar trauma scores in children based on skeletal maturity, and refutes the published literature that these scores apply broadly to the pediatric population. So these findings support the development of a classification and treatment algorithm that is specific for skeletally immature patients with open triradiate cartilage. And thank you to everyone who supported this research, and thank you for the opportunity to present today.
Second session. Any questions?
Question for Lisa. Nice presentation. Now, just because they didn't have surgery doesn't mean they didn't need surgery. How can you differentiate whether the surgeons didn't perform or the classification didn't perform?
Yeah, that's a great question. And so I kind of mentioned this briefly, and it's something that we looked at in the overall population. Was we followed them. We looked through their chart for any additional complications afterwards, or if they had like a delayed need for surgery. And of course, there's always a limitation within pediatric populations, because eventually we often lose access to our patients as they grow. So it's hard to know if eventually one day they needed surgery, if they developed like early onset kyphosis as secondary to these injuries. But at least in the data that we had, there were no significant complications of the patients who were inappropriately recommended for something based on this scoring criteria. So from what we can tell, the treatment they actually got was good, if that makes sense.
Dr. Lin's group, the the S2 Ayler screw study, noticed that the gentleman with the big PSIS and the more medialization of the screws, has that modified your technique? Are you guys doing just a PSIS osteotomy with connectors, or are you just accepting bent rod with more medial heads?
From what I'd seen in all of the research, it seems like there was.
So the impetus is that I noticed that, in men, I was spending some time contouring the rod more medial. And that became a lot more apparent when I started using pre-contoured rods, where I really wanted to drop them in straight sagittally, and then I had to bend them or rotate them out of plane, and then their lordosis is not correct. And so now I really pay a lot of attention with navigation to really lateralize as far as I can the S2AI screw start point under the PSIS. Sometimes I'll even use a medial iliac screw rather than S2AI screw just to make sure it lines up. And then you can also kind of sort of alter your S1 screw start point slightly more medial, so not really have such a aggressive lateral to medial trajectory to try to get everything to line up straighter. So I think it just makes it easier to contour the rod.
And along with those questions, these numbers are low. It seems like when you get failures, it's either the rod fracturing. Do you think the lack of alignment has to do with it, or is it just a strain on the construct osteoporotic bone?
We really didn't see any change in the rate of failure with the rod alignment. I think it's more with in relation to making sure you have, I think cosmetically it looks better on the AP X-ray to have the rod straight. Also, when you're using pre-contoured rods, having the rod aligned sagittally makes sure because you imagine if you have a lordosis in the rod, you rotate it 9 degrees, you have 0 lordosis. So you want to make sure that your pre-planned, curvature kind of is accurate.
I have a question for Dr. Marmor. A great study comparing the tethering versus the fusion. Obviously, the two groups are different. I assume you can't really tether everybody, but the fusion is you have a much broader application. But it is interesting to see that the tethering group has almost half the length of stay, but the cost is a little higher. Are the higher costs mainly contributed by the cost of the tethering because it's a newer technology, or is there any other factors contributing to that?
From the database, we're not able to get that, but my assumption is that it's due to the implant itself. There's not much of a market for competition for tethering versus for fusion. And then also for tethering, you almost always have two surgeons. You have the approach surgeon and then the orthopedic surgeon who's doing the tethering. So my assumption is there's also increased cost due to that. We have no patient report outcomes from this data set. It doesn't follow patients that much. It's mostly a in-house, in-hospital data collection study. But future directions will be to try to follow patients that we are operating on at University of Miami and Jackson to see what their outcomes are, radiographic and patient report.
Okay, I'm happy to introduce our next abstract presented by Miles Hudson, the assessment of transitional slippage between upright X-rays and supine MRI for spondylolisthesis.
All right. Thank you, everyone. My name is Miles Hudson. I'm a PGY6 at the Mayo Clinic Arizona campus, and I'm excited here to talk today about some of the research we're doing. So, how do I advance it? All right, perfect. I have no disclosures, and I'd like to thank my mentors who helped on this project. So, this is something we've seen here at our campus and in our clinics is, there's a lot of research looking at spondylolisthesis, especially between x-rays and MRI. And what we know from the literature is that when you lay someone supine, they reduce. When you have axial loading and these additional force and stressors, the slippage tends to be exaggerated. But when we're assessing these patients with spondylolisthesis in our clinic, we're always getting these flexion extension x-rays, right? These are the gold standards. And I'm sure everyone has seen these patients in their clinics with this lumbar spondylolisthesis. You get the flexion extension x-rays and they don't move. But then we look at the lumbar MRI, they do move, right? So we specifically looked at this patient cohort, this subset of patients with lumbar spondylolisthesis that had upright flexion extension x-rays but did not move. And then we compared that to how that moved on the supine MRIs. So we looked at patients over a 5-year course, and this led to about a couple thousand patients being found during this review of our imaging database. When we subset those, so we moved all the patients with, iatrogenic issues, spondylolysis, all the other issues. It was pretty much just lumbar degenerative spondylolisthesis patients we were looking at. And in this cohort, we ended up with about 114 patients and 185 levels of lumbar degenerative spondylolisthesis. And then you can see here in panel C and D an example of this, a patient with a lumbar upright flexion extension x-ray and then their supine MRI imaging that does show reduction of that spondylolisthesis. And again, specifically patients that did not move when we had them upright and flexing and extending. What we found from this was that pretty much all of these patients had some level of degree of reduction. So even though they're kind of fixed due to their lumbar degeneration on the upright imaging, they do move when you lay them flat. Not only this, but all of these patients did move, and the movement was correlated with a degree of slippage. So patients with more slippage, even if though they didn't move on the upright imaging, did move and moved more when we laid them flat in the supine imaging. And this was found across all levels, anterior versus retrolisthesis, grades 1 and grade 2 spondylolisthesis as well. We performed a cut point analysis to look at these patients in this subgroup of patients to see how did this affect their progression to surgery. So we looked at, fusion versus decompression and everything else in this patient group. And what we found was that in our patient cohort, patients with more than 2.6 millimeters of slippage when laid flat did more likely to proceed to surgery. And this is pretty close to the standard publicized level of 3 millimeters of slippage when looking at stable versus unstable lumbar spondylolisthesis. There was no difference in our cohort with degree of slippage and whether they progressed to fusion or decompression. And when they progressed to surgery, they were specifically in patients who failed conservative management. They failed injections, they failed PT, and then they had symptoms and surgery at their index level of that spondylolisthesis that we measured. And I think this is pretty interesting because it kind of shows that when you get these patients with lumbar degen spondylolisthesis and they don't move on x-ray, you really need to think about how much they're slipping and, get additional measures, whether that's supine x-rays or you can get the MRI as we did in this cohort. We looked at the MRI specifically because a lot of these patients are getting MRIs routinely anyway. So we can look at that and see that, some of these patients we're classically finding as stable may actually be unstable, even though they don't move on flexion extension x-rays. And about 30% of our patients in this cohort did meet that 2.6% cutoff. So, we're planning on doing more research in this and doing other things, but, potentially that's a subset of these patients that have occult instability that we're not finding by purely relying on these upright flexion extension x-rays and saying, hey, they don't move. This patient might be stable. Maybe it's okay to do a decompression. I can get away with maybe an MIS decompression on this patient. But actually they may be unstable and you might want to consider fusing that patient or, adjusting your treatment modalities. Thank you.
All right, thanks very much, Dr. Hudson. Our next speaker is Dr. Kai Wang, who will speak about comparisons between outcomes of 3 different OLIF constructs.
Sorry, it's not my.
Well, different PowerPoint.
Yeah, different.
Do you have it? We can have the next speaker go, and then while you upload, why don't you give it to him? We can move on to the next speaker, Dr. Hao Wu, on clinical outcome and complications for multi-level standalone OLIF. While Dr. Wang's PowerPoint is being loaded.
Good morning, ladies and gentlemen. It's a great honor to be here and to present on behalf of my colleague, Professor Wu Hao, and unfortunately he's unable to come here. And my topic today is multi-level standalone olive for the treatment of degenerative lumbar scoliosis. I have no financial disclosure. As we all know that multi-level olive can be used for treatment of multi-level spinal stenosis or scoliosis and so on. And routinely, we need to do internal fixation to facilitate the fusion and also to keep the spine stabilization. And this is a mid-step algorithm for ASD. And in our center, we usually do stage surgery for class 2 and class 3 subgroup. And typically, on first stage, we do multi-level olive and then recess the patient. And typically for class 2, we usually do direct PPS on second stage, and also if they have residual symptoms, we will do a direct decompression for the reasonable segment. And for class 3 subgroup, we may do osteotomy, and if they got to do L5 to S1 fusion, if they get fractional curvature. There are interesting things that many Chinese people they are unwilling to accept fixation. So if we come across some patients that they refuse to do stage 2 after they got a satisfied recovery after stage 1 surgery. So we summarize this subgroup of patients, the total 10 patients. Included, and overall, at a minimum of 2-year follow-up, these patients may maintain good clinical status, and the symptom relief very good. And among the 10 patients, the 2 patients experienced VS aggravation. And this is a radiographic assessment that showed that disc height improved significantly postoperatively. And multivariate regression analysis so that imbalance risk factor for poor outcome. Show some cases. As in case 1, we see that this female got slight scoliosis, but they got no imbalance. And after stage 1, is doing great. And during 2-year follow-up, the symptom remains stable. And this case 2 with a male patient, they got no imbalance, but he got thoracic and lumbar kyphosis, and not surprisingly, this did not improve after stage 1. So we encourage him to do stage 2 to further correct this kyphosis, but he refused to do so because he thinks that his symptom relief good. And in case 3, you can see that the patient got scoliosis, mild scoliosis, but his balance is good. So after the first stage, we see that the slight subsidence of the cages. And after 1-year follow-up, the symptoms aggravated. So we did the internal fixation for her. And the symptom relieves, even though they got coronal imbalance, but still follow up for her. So conclusion, case number is limited and multi-level can make improvement for this mild ASD patient. And subsidence and fusion rate is surely lower in this group of patient, and internal fixation is indicated when the patient got imbalance. Thank you very much.
Thank you very much. Our next speaker will be Dr. Wong, comparison of outcomes of 3-level OLIF constructs.
Well, in the interest of time, maybe we'll just discuss the first two. I have a question for Dr. Wu. So it looks like the interbodies all are, it's peak interbodies for those lateral olive cages, peak. And do you use the BMP with it, or do you actually use titanium as well? And do you see a higher? Because I think in the U.S., peak is falling out of favor because of the reported lower fusion rate compared to titanium implants. But the flip side is that titanium is a little stiffer and it seems to cause more subsidence. So do you have experience with either cage material, and any comments?
Thank you for the question. Titanium cage is better, I think, but it is not allowed in our hospital. So we only have peak cages. When we do the insertion of the cages, I usually use artificial bones, and we will also use some blood from the bone marrow, and to facilitate the fusion rate. Yeah.
How about the BMI or body weight? Like more load?
Yeah. The high BMI and poor osteoporosis patient, but I have to say that this is not routinely we do standalone. We routinely do the fixation. But this kind of this subgroup of patients, I think, is a kind of deviation of our protocols. So we usually do we mostly do a fixation for this group.
Once fail, harder to get out.
Yeah. It's true. There are several cases at the very beginning of our procedure, but I think after doing many cases, our technique, I think, is improved. So the protrusion of the cage into the vertebra is not happened very much, and we will assess the bone density for every patient. If this got a serious process, I think we will first correct the status and then do this kind of surgery.
Okay, thank you. Good morning, everyone. I'm Dr. Kawan from Neurosurgery Department of Shim Hospital. My topic is perioperative clinical features and long-term prognosis after 3 different olive constructs. I have nothing to disclosure. As well known, olive is a very popular minimally invasive surgery, and usually have 3 constructs. Standard olive, as we all know, save time and blood loss. However, due to its lack of support, it may have greater cage subsidence rate and also lead to loss of indirect decompression. Olive with anterior fixation provides some support, but this support may be not enough, and also it have high risk of damage of the structures in the lateral corridor.
Olive with posterior fixation is gold standard. However, it's take much more long time and also may induce atrophy and fat infiltration of the paraspinal muscles. So our study is to decide which fixation construct is better. Our study including 71 patients divided into 3 groups. And obviously, standard Olive has shorter operative time and less blood loss. And after the final follow-up, there were no significant differences in clinical symptoms among 3 groups. And Olive with posterior fixation shows better in restoration of disc height and also the foraminal height. And both Olive with posterior and anterior fixation has achieved better restoration of foraminal area. The standard Olive group had a higher rate of cage subsidence, obviously, and the subgroup analysis revealed no differences in clinical and radiographic outcomes with respect to age, gender, number of segments, and also the bone mineral density, and no significant differences in clinical improvement among the different fixation methods. There are 3 cases. The first one is standard Olive. Second one is Olive with lateral fixation, and third one is Olive with posterior fixation. All 3 cases shows improvement in clinical and radiographic results. So our conclusion is among 3 fixation strategies, among 3 fixations, clinical outcomes do not differ significantly. However, posterior fixation still better than others in radiographic results and remain the gold standard. If the patient is in good condition, then the standard Olive may be considered, and it may achieve the favorable clinical result and offer great comfort because it has no fixation. And if the ligament is damaged during surgery, then the lateral fixation should be considered. Thank you.
Thanks very much, Dr. Wong. Our next speaker is William Marmer, who will present on chronic steroid use and its impact in the clinical outcome of microdiscectomy surgery.
Hi, everyone. Again, I'm Will Marmore, ortho resident at University of Miami. I'm presenting for Levi Travis, who wasn't able to make it. So this study was chronic steroid use and its impact on clinical outcomes of lumbar microdiscs. Again, I have no disclosures. So lumbar microdiscs are considered safe and effective procedures. Chronic steroid use has been linked to impaired healing as well as postoperative infections and a number of spinal procedures. So the aim of this study was to evaluate the association between chronic steroid use and 30-day complications following elective lumbar microdiscs. So for our methods, we performed a retrospective cohort study on a large national database from 2016 to 2023. We included adults who underwent elective lumbar microdiscs, and then we excluded any patients who had disseminated cancer, had preoperative sepsis, or concurrent fusion procedures performed. We performed a 3-to-1 nearest neighbor propensity score matching for a number of different potential confounders, including BMI, ASA, diabetes, COPD, smoking. And then we performed a multivariable logistic regression. So here we have a kind of a diagram of these methods. We were able to identify 64,000 patients who underwent elective lumbar microdiscs, and then we found about 2,400 of those patients were using chronic steroids. With our matching, we found about 7,200 patients that were able to be matched, so we had a total of 9,600 patients. And we found no significant differences in patient age, sex, BMI, the ASA classification, or any other comorbidity burdens. And then we performed our logistic regression. So what we found was that patients who were using chronic steroids before their lumbar microdiscs had a higher 30-day readmission rate. They had a higher risk of developing pneumonia, developing DVT, and developing sepsis as well. There was no difference in operative time, transfusion rates, or length of stay, as well as discharge location. So with this data, we concluded that chronic steroid use pre-op for lumbar microdisc may be associated with increased risks of postoperative sepsis, DVT, pneumonia, and hospital readmission. And so really the aim of this is to not change, we can still do lumbar microdiscs on patients who are taking chronic steroids, but just keep in mind that they are higher risks for these complications and to inform patients of this prior to surgery. Thank you.
Thanks very much, Dr. Marmer. All right, and our final speaker for this section is Dr. Hunter Yamada, 5-year outcomes of the SLIP trial for lumbar spondylolisthesis.
Hey everyone, I'm Hunter Yamada. I'm a medical student at UCSF. And before I start, I want to thank all the senior QOD authors, especially Dr. Shaffrey, Dr. Haid, and especially Dr. Mumaneni. So I'll be talking about decompression alone versus decompression with fusion, TLIF for degenerative lumbar spondylolisthesis. Do the 5-year results differ when comparing only minimally invasive surgeries? So the SLIP trial reported that there was a clinically meaningful superiority of fusion compared to laminectomy alone in degenerative grade 1 spondy. But we wanted to know whether or not this applied to MIS TLIF versus MIS decompressions at 5 years postoperatively. So a previous 2-year study from the QOD group demonstrated that MIS TLIF versus MIS decompression had lower reoperation rates, roughly 1.4% compared to 14.1%, as well as superior PROs for TLIF. So if you look at the cohort, these cohorts are overall well balanced, but the MIS cohort was a younger cohort and had back pain as a dominant symptom versus leg pain, as well as having lower rates of motor deficiencies and higher NRS back pain scores at baseline. The outcomes of interest that we're looking at patient-reported outcomes such as ODI, NRS leg and back pain, EQ5D, as well as NAS satisfaction scores, and as well as looking at reoperation rates. So we also performed univariate analyses looking at both intra-cohort to see whether or not they improved from their baseline, as well as inter-cohort to see whether or not there are differences between our fusion and non-fusion cohorts, as well as a multivariate analysis to look for potential predictors. What we found is that the MIS TLIF group had a lower 5-year reoperation rate of 2.8% versus 15.5%. And if you're paying attention to that, the slide of the Vegas thing, that's roughly the difference between rolling snake eyes versus rolling a 7. So keep that in mind. In terms of reoperation at 5 years, you can see that the reoperations that occurred for MIS TLIF were all adjacent segment disease. And this is sort of similar to what was found in the SLIP trial as well. Looking at the intra-cohort, we found that there were significant improvements in all measured PROs from baseline for both cohorts. Now, when you look at inter-cohort and compare the fusion versus decompression alone, there were no differences in the rate of achieving MCID for all PROs. However, the MIS TLIF group did have a higher satisfaction rate. Now, multivariable analysis demonstrated that MIS TLIF versus MIS decompression did not affect the 5-year ODI, NRS back leg pain, or EQ5D, but they did find that baseline scores were predictive for ODI changes, as well as NRS back leg pain and EQ5D. Essentially coming to the conclusion that the baseline PRO scores at the 5-year time point are what seem to best predict what the PROs will be, and that the superiority of MIS TLIF versus MIS decompression that was seen at 2 years does not extend to the 5-year time point, sort of indicating a different recovery course. But we did see that there were fewer reoperations in the TLIF group versus decompression, as well as higher patient satisfaction. So it's important to note that these are equivalent and basically equivalent to previously reported as well. Thank you.
Questions? Any?
So obviously a grade 1 spondy can be a lot of different things. Can you talk to a little bit about how patients were included or excluded?
So it's my understanding that in terms of the grade 1 spondy that were included in the group, are you talking about for the surgery specifically, or just like whether or not it was like ischemic or degenerative? Okay.
Yeah, so they're all radiographically confirmed myridine grade 1 spondy. So I'm assuming it's just the 0 to 25% grading for grade 1 spondies. And then in terms of the surgery types, it was classified as a decompression only if it was like a tubular decompression, since we're looking at MIS.
I have one question for Dr. Marmer. One of the hardest things when we got to look at these databases is actually having any granularity on the patients that we're comparing. It's hard for me to kind of justify how a patient population that's on chronic corticosteroids would be the same same as a patient population that's not. And do you have any idea if it's actually the corticosteroids or the disease process for which the corticosteroids are being used for that are causing the higher rates of complications?
Yeah, so definitely a good question. I think the propensity score matching is what helps to control for at least the comorbidities. So I think based off of that, we assume there's a higher likelihood that it's coming from the corticosteroids themselves, just because we did the propensity score matching for those comorbidities. But I agree it's hard to get granularity from these large database studies.
They're trying to figure out if it's actually the disease that they're taking this corticosteroids for that puts them at higher risk. It could be a whole bunch of people with asthma, which would not be a big deal, but it could be also people with, inflammatory arthritis, chronic rheumatoid disease, all sorts of things that have multi-system problems as well. So it seems something that needs to be studied more.
Yeah, definitely. I mean, if you're on chronic steroids for lupus, your likelihood of DVT is going to be much higher. So it's a good point.
I've got a question, maybe Dr. Yamada and Dr. Hudson, both really good presentations. It was interesting to me, the decision-making, Dr. Hudson, with regard to decompression only versus fusion, that it really didn't depend on motion. And I wonder, maybe both of you can answer, what really do you think, based on your research of these cases, drives the decision between decompression and fusion? Maybe does Dr. Yamada want to start with that? Or?
Yeah, I don't know that he knows all the detail because it was 15 sites worth of people. So they were all grade 1 degen spondy. The type of surgery that was done was not randomized. It was prospectively collected. It was up to the surgeon. We had some surgeons who tend to do more decompressions. Some surgeons tend to do more fusions. Now, the issue is it's over 14 sites. So because the numbers are so large, the actual number of patients that was enrolled here was like well over 1,000, or close to 1,000, like 700-ish patients. Of those, there was 140 that were MIS. That's the subgroup that got analyzed here. But they're spread over so many different sites, and it was up to the surgeon. I think you're right. Some people will say, if somebody says I have more back pain, they'll tend to fuse them. If someone says I have more leg pain, maybe they'll try to decompression. But when you just look at the overall, the number of people who are coming back at 5 years, there was 80% follow-up here at 5 years. Like trying to get 80% PROs at 5 years, that's not easy across 14 sites. But when you look at that, the number of people who had re-ops was like 10 times higher than if you did a decompression alone. That was the interesting thing. We didn't think there was going to be a difference.
Yeah, no question that it's a well-designed study with good follow-up. The issue is, it would be interesting to look at and see what the predictors are. Yes, guys' analogy is a little bit off too. It's actually more of a difference to get a 7 than snake eyes than it is for it's 15-fold difference versus about actually it's pretty close, about a 23-fold difference. How about Dr. Hunter? Can you tell us what's that?
Oh. I think if you look at the cohorts themselves, like the MIS TLIF cohort was a little bit younger as well. So like Dr. Mumaneni said, like some surgeons may have different preferences in terms of like the way they like decide. If you're younger, if you see that there's a reoperation rate that's lower for MIS TLIFs, that might influence your decision to put in a more robust construct in younger patients versus older patients. So I think patient characteristics sort of might be coming into play, and that'd be something to look into, is how people decide what surgery to proceed with. Oh.
Yeah, so I think that's an excellent question. You know, with our group and our campus, a lot of it really depends on the patient and the symptoms. You know, you have an 80-year-old lady with grade 1 spondy without a lot of motion. You know, she's coming in with symptoms that are primarily addressed maybe through a decompression versus fusion. Some of our surgeons might elect to just do the smaller operation given her age and additional comorbidities. But, you know, what we also plays in a factor is going to be the instability, as you say. So if they have a lot of motion on that imaging, you know, we might say, well, you know, given this, we think you're going to fall apart and you might need a fusion. But for our study specifically, it was just patients without motion. So in patients without motion on their x-rays, they were still moving when we laid them flat. And that 30% of those patients, you know, had more than 2.6 millimeters of movement, which in our cohort was predictive of progression to surgery. So I think some of it comes down to just making sure we fully evaluate these patients and making sure the spondylolisthesis itself may be mobile when we're saying it's not, I guess was kind of our takeaway.
Yeah, just to add to that, did you have any patients that were mobile on their x-rays, but not mobile, not reduced on the MRI?
Another great question. We actually didn't see any patients that, that were non-mobile. Sorry, I'll make that sure. Mobile on the MRI, but not mobile on the X-ray. We didn't see any cases of that. And again, that fits with the literature showing that when you take away the weight, people tend to reduce. But we did see instances where it was similar. So they might have a, 2 millimeter slippage, and on the MRI, 1.9 millimeters, so almost equivocal. So we did see quite a few patients who were about the same, even though that they, the same X-ray versus MRI.
So does that mean that we should probably not get flexion extension MRIs, X-rays? We should get like a flexion and supine bolster or something like that instead of doing our traditionals?
I don't think that by any means, because our patient cohort was so specific, right? Like only patients that don't move, don't have a spondylolysis, no ankylosing spondylitis, or all these other degenerative disorders. I think it just means in these patients that don't move and you have a high suspicion. So let's say they have a 3 millimeter, 4 millimeter slip or a grade 2 slip. And you might be a little bit more keen when making that decision, look at the MRI or get an additional modality. But I think flexion extension X-rays are still the gold standard.
Yeah, I have a question for Dr. Wong or Dr. Wu. What was the diameter of the OLIF cages that were used, and do you think the diameter that you use of the cage affects the subsidence rate?
Yes, thank you. It's a very good question. We usually use leg size 13 or 11, 13 cage size. Height, width like 22. Yeah, we use most cases we use Johnson & Johnson cage. That's 22. Yeah.
All right, so we'll move on to the last session before the awards. I think what we'll do is, before the very end, we'll get to the top 3 abstracts from each judge. We'll have 9 judges, and then we'll tally the score and then present the awards. So the final section will be kicked off by Dr. Janet Balkiloa on respiratory complications in OC fusion.
Good morning, everyone. My name is Jeanette Balkiola, and I'm a medical student here at the University of Hawaii Medical School, and it is truly a privilege to be able to talk with you folks today about respiratory adverse events in occipitocervical fusion. I have no financial disclosures. So occipital cervical fusion is a procedure used to address abnormalities which impair instability at the craniovertebral junction. Now, this procedure carries the rare but critical risk of respiratory adverse events, otherwise known as RAEs. Now, patients undergoing OCF are at greater risk of RAEs due to the cervical hyperflexion required both intraoperatively and postoperatively, as well as adjusting to the significant anatomical changes post-operation, which can lead to further airway narrowing. So my team and I conducted a systematic literature review of OCF cases with reported post-op RAE outcomes, specifically focusing on incidence, severity, and risk factors in hopes of providing further recommendations on management strategies following operations. So, looking at our results, the majority of patients experiencing RAEs post-OCF were adult males who underwent about a mean of 5 fused cervical vertebrae levels. Amongst those, the most common indications for OCF surgeries were inflammatory conditions like rheumatoid arthritis, and then congenital abnormalities like Chiari malformations. So, RAEs occurred in about 12% of our cohort, and they were most commonly due to delayed extubation, respiratory failure, and upper airway obstruction. Now, amongst those cases that had reported extubation outcomes, pediatric patients actually suffered a higher degree of delayed extubations. Now, when we further stratified those RAEs based on severity, it turned out that severe cases necessitating surgical revision were seen exclusively in our adult patients, whereas our pediatric patients experienced exclusively delayed RAEs. So, the severity of RAEs, although rare, as well as their distinct clinical interventions and varied presentations, necessitate a robust pre, intra, and post-operative management strategies. Now, patients that have congenital abnormalities or suffer from conditions that lead to inflammation and stiffness at the craniovertebral junction are further at risk for impaired intubation, surgical positioning, and post-op alignment. Furthermore, the prevalence of age-specific complications was highly seen in our studies, further supporting the notion that both pediatric and adult patients experience distinct airway vulnerability patterns. Now, in children, the cervical hyperflexion required in operations exacerbates already immature cartilaginous structures, as well as structures that are suffering from increased tissue compliance, leading to further airway narrowing. Now, conversely, in adults, when RAEs did happen, they were more abrupt and tended to be more severe as a result of post-op complications exacerbating age-related impairment. In conclusion, the rarity of RAEs post-OCF does not underscore their ability to cause significant impairment and permanent impairment. Now, identifying high-risk populations, particularly patients suffering from etiologies which lead to instability at an already fragile and impaired cervical spine, is going to be one of the first steps that we can take to further reduce RAEs and overall improve patient outcomes. Thank you very much.
The abstract is from Dr. John Wall on laminoplasty versus lami fusion in smokers.
Good morning. My name is John Wall. Today I'll be presenting our systematic review on the outcomes following laminoplasty versus laminectomy and fusion in smokers. My co-authors and I have nothing to disclose, and the views expressed herein are our own. Smoking remains highly prevalent, with roughly 1 out of 5 U.S. adults still using tobacco products, and the majority of these products being cigarette use at roughly 60% of users. Tobacco use is even more prevalent in the military population, with nearly 30% of active duty adults using tobacco products. Additionally, smoking is known to increase the risk for non-union orthopedic procedures. Our hypothesis was that complication rates would be lower in smokers undergoing a cervical laminoplasty when compared to a cervical laminectomy and fusion. We performed a search on PubMed in January of 2024 with a repeat search in April of 2025, with keywords being posterior cervical fusion, cervical laminoplasty, smoker, and smoking. Our inclusion criteria included randomized controlled trials, case control studies, cohort studies, and case series. Exclusion criteria included papers not including smoking status in the demographics, those that included an anterior or combined approach, and those that did not report on union rates, pseudoarthrosis rates, or complication rates, with our outcomes of interest being complication rates and fusion rates. Based off this search, there are 54 articles identified, 13 that met our inclusion criteria. For fusion data specifically, there are 4 articles for posterior cervical fusion and 1 for laminoplasty. And for complication data, there were also 4 articles for posterior cervical fusion and 6 for laminoplasty, with some examples of the complications reported on the right side of the screen. Looking specifically at the fusion data, for posterior cervical fusion, there are 4 articles identified, with only 1 of the 4 finding an increased rate of pseudoarthrosis among smokers, and the remaining 3 finding no difference in outcomes based on smoking status. For laminoplasty, there was 1 article identified which looked for healing at the laminoplasty hinge sites 12 months postoperatively via CT scan, and they found no difference in the fusion rates by smoking status, with some examples on the right. For complication outcomes, for posterior cervical fusion, there was additionally 4 articles identified, with 1 of them finding an increased rate of readmissions, surgical site infections, and reoperations among smokers, and the remaining 3 finding no difference in overall complications, surgical site infections, hematomas, or C5 nerve palsies based on smoking status. For laminoplasty, there was 6 articles identified, with all 6 finding no difference in rates of total complications, reoperations, readmissions, surgical site infections, or C5 nerve palsies based on smoking status. So in conclusion, our work was similar to prior published works in that there is both mixed outcomes in both fusion and complication rates in smokers who underwent cervical laminectomy and fusions, but smoking did not appear to affect the bone healing site at the laminoplasty hinge site or increase the rate of complications after this procedure. These results suggest a possible benefit in active smokers who are eligible for both procedures to undergo a cervical laminoplasty over a laminectomy and fusion, but further research and head-to-head trials on this is needed before any conclusions can be drawn. Thank you.
Our next speaker is Ashil Sousa on real-time ultrasound-guided posterior lateral thoracic discectomy.
Good morning. I'm excited to present our abstract titled Real-Time Ultrasound-Guided Posterior Lateral Thoracic Discectomy. It was done under the guidance of Dr. Lee Tan. I have no disclosures. So the background of the study is that thoracic disc herniation is a relatively rare condition, contributing to less than 1% of all disc herniations. Despite this, it's clinically significant with neurological symptoms such as myelopathy and radiculopathy, making surgical treatment necessary for symptomatic relief. But TDH surgeries have higher complication rate compared to cervical and lumbar decompression surgeries. The reason for this is access to the thoracic disc is challenging given the thoracic spine's relatively narrow canal and the spinal cord blocking direct access, making visualization difficult. Over time, there have been several approaches developed to access the TDH, all with their limitations, but of late, posterior lateral approach is becoming popular given its low complication rate, but the main drawback is its limited access. So our study aims to evaluate the safety and efficacy of using real-time intra-op ultrasound in posterior lateral discectomy for TDH treatment. The study design is a retrospective analysis with patients with symptomatic TDH enrolled between May of 2020 and Feb of 2025. A total of 32 patients were enrolled. The data was analyzed using SPSS and P of less than 0.05 was considered significant. So the surgical technique is marking the TDH level, confirming it using fluoroscopy, skin incision, and dissection is carried out. The spinous process and the ligamentum flavum is exposed. The probe is prepared, and then the surgical cavity is filled with saline, and then the probe is used for visualization. So here's a short snippet of what would be seen on ultrasound. So as you can see, the surgeon can visualize the spinal cord, the calcified disc, the instrument used for manipulation, and the interface between the cord and the disc, in addition to the dura and the CSF. Our patient cohort had a mean age of 58, 46% of them were male. The mean BMI was 30. They had poor VS and neuric grade. The comorbidities, 34% of all patients had one of these comorbidities. 50% of our patient cohort had disc calcifications, and 2 of them had giant thoracic disc herniation. The mean operative time was a little over 2 hours, length of stay approximately 5 days, estimated blood loss around 120 cc. The mean radiological follow-up was for 8 months, and 84% of our patients had grade A definite fusion, and only 1 patient had possible pseudoarthrosis. The mean clinical follow-up was for 2 years, with the VA score improving from 6.2 to 2.1, and the neuric grade improving from 2.9 to 1.1, both of them being statistically significant. The advantages of this approach is it avoids the complications of intrathoracic complications of the anterior approach. It spares the paravertebral muscle dissection that is inherent in the lateral approach. And given the use of ultrasound, the posterior lateral approach can be used even in cases of calcified or giant disc herniation. As in this case, we have a calcified disc, a compressed spinal cord, and a decompressed spinal cord post the procedure. Overall, we had good functional outcomes and radiological outcomes, and we believe using ultrasound addresses the constrained working corridor in the posterior lateral approach. Comparison of our study with a 2017 study and a 2023 meta-analysis showed that the length of stay was shorter in our study, lower estimated blood loss, a lower mean operative time, and comparable outcomes. The drawback is the surgeon needs to have advanced proficiency in ultrasound use. There's need of instrumental spinal fusion, and there may be a steeper learning curve. Despite these limitations, we believe they're worth overcoming given the clear benefits in safety, visualization, and outcomes. In light of this has been recently accepted for publication in operative neurosurgery, and we believe this technique will gain increasing traction and clinical adoption in the next years. These are my references. Thank you for listening.
There is one of our fellows, Jay Kumar. Does pre-op EMBO help decrease blood loss and transfusion rate in non-vascular spinal meds?
Good morning, everybody. My name is Jay. I have the honor of being Dr. Tan and Dr. Mumanani's fellow, along with my co-fellow, Niall. And today I'll be presenting some research done by the UCSF spine team. And my thanks to the many co-authors, including Dr. Theologist, Dr. Bervin, and of course, Dr. Tan, Dr. Mumanani, and Dr. Allen. And of note, this work was spearheaded by our outstanding medical student, future Dr. Vardhan Ampati. So our talk today was looking at whether preoperative embolization helps to lower surgical blood loss and transfusion in non-vascular spine mets. I, of course, have no personal disclosures. So whereas it's known and somewhat routinely done to have pre-op embo for tumors that are classically vascular, the jury's still a bit out on whether pre-op embo helps with tumors that are considered to be non-vascular. And that's what this study looked at. So we looked at vertebral column mets that underwent resection that either did or did not have pre-op embo. And we excluded those that were known to be vascular, including renal, hepatocellular, and thyroid. Both univariate and multivariate analysis were performed, and a propensity score analysis was also executed. So the full cohort was 235 patients, of which 33 underwent embolization. The top three most common found pathologies were breast, prostate, and lung, recapitulating what we find in the general population. And the findings of the univariate analysis were these: that surgeries with embolization happen to have more levels operated. This was statistically significant. But to cut to the chase, there were no differences in estimated blood loss, change in hemoglobin from pre-op to post-op, rate of transfusion during surgery, or the units of blood transfused. Interestingly, the EMBO cohort did have a statistically higher post-op hemoglobin, though this was not clinically meaningful. And again, there was no change in hemoglobin. The multivariate results were similar. Their embolization was associated with a higher post-operative hemoglobin. However, it did not affect the blood loss or the rate of transfusion or the amount of transfusion. In the propensity score matching, the cohorts were all matched with a maximum match of 1 to 3. There were no differences in baseline characteristics. And again, there was no meaningful difference in transfusion rates or amount. So in conclusion, we found that in these non-vascular mets, preoperative embolization did not improve EBL, did not improve transfusion rate, and did not improve the rate of transfusion, though there was a higher post-operative hemoglobin level. Thank you so much.
Our last talk. So for all the judges, please pick your top 3 abstract, and then we'll quickly tally the total score from everybody and then present the award. So our last talk is Abe Dada from UCSF. He's going to give us talks on SIN score and how it affects the cervical spine mets.
All right. Good morning, everybody. My name is Abe Dada. I'm a fourth-year medical student at UCSF in my research year. I'd like to thank the senior authors for their mentorship on this project: Dr. Allen, Dr. Mumanani, Dr. Tan, Dr. Bervin, Theologist, and Clark. I'll talk about cervical metastatic disease and functional outcomes of these patients. And I have no disclosures. So METs of the cervical spine is relatively rare. Functional outcomes in this patient population are poorly understood. We took a look at 46 patients with cervical spinal METs in our database of over 500 patients with metastatic disease at UCSF. We looked at their baseline demographic and clinical variables associated with MCID for KPS at last follow-up in these patients. We were looking at the SINS scoring for these patients, obviously excluding or subsetting location to the cervical spine. We looked at pain, the type of bone lesion that these patients had, their spinal alignment, vertebral body collapse, as well as posterior involvement of the metastatic disease. So at baseline, those who achieved MCID and KPS and those who did not had very similar tumor types. There weren't really any differences in their baseline demographic factors as well, like age or female sex. Those who achieved MCID and KPS at their latest follow-up did have higher SINS pain ratings at baseline. We noted that the composite SINS score was pretty similar between these groups. We also noted that there was a higher use of post-op radiation in those who improved. Otherwise, the type of surgery that these patients had in both groups, the chemoradiation and blood loss were pretty similar. Multivariate analysis, again, recapitulated the univariate finding that those with higher pre-op SINS pain tend to benefit more from surgery. Older patients and those with higher baseline KPS didn't benefit as much from surgery. So in conclusion, 50% of patients with cervical metastatic disease achieve MCID for KPS following surgery. Patients with higher baseline SINS tend to benefit more. Older patients and those with higher pre-op functional status are less likely to improve following surgery. Thank you all.
We can start discussions. Any questions, authors?
Question for Jeanette Balchiola. You mentioned, I think, a 12% respiratory complication rate or maybe even higher for these patients undergoing these high cervical fusions. Can you tell us what are your ideas about implementing a protocol for these cases so you can standardize best outcomes and best practices for these patients?
Thank you for your question, Dr. Metz. Unfortunately, that was one of our limitations of doing a systematic review, is that our results were at the liberty of the publicating authors, depending on what they choose or didn't choose to include into their reports. Based off of the trends that we did notice, implementing a multidisciplinary approach when planning for the OCF fusion surgeries, I believe, and my team believes, that would improve patient outcomes the most. So not a lot of our cases that we included were simply had commentary from the neurosurgeons who were assigned to the case, but additionally integrating radiology early on, as well as primary care who have identified these congenital or concurrent conditions would potentially improve outcomes. So thank you.
Oh yeah, actually, don't take that away yet. Follow-up question to that would be, it's in adults, the indications for the OC fusion are often different from children. Mm-hmm. And how do you know that the levels of fusion also play a role in like dysphagia, aspiration that lead to respiratory compromise as well? So it's trying to figure out exactly who's at risk. Can you specify who specifically would be at risk? Like, is it children with trauma that might have neurologic injuries that are already at risk for a respiratory problem? Is it different from the adult with rheumatoid arthritis that has OC fusion for basilar vaginatum or cranial settling, right? Can you comment on that?
Yeah, most commonly our pediatric patients who would be most at risk are those that demonstrate pre-existing congenital diseases like Chiari malformations. So already at baseline, they're at increased instability and vulnerability of their airway. Compared to adults, diseases that impair and compound upon already age-related degeneration are going to be most at risk. So people who have the inflammatory conditions like rheumatoid arthritis, and predominantly those who suffer trauma that lead to cases that could predispose them to airway obstruction were the ones that we identified.
Perfect. A question for Dr. Kumar. Again, a really great presentation, and specifically with regard to non-vascular tumors, there certainly is a lot of variation in vascularity between tumors we consider vascular versus non-vascular. Are there any radiographic features on the MRI that might lead you to think about embolization in a traditionally non-vascular tumor? And then it looks like the surgeons did a pretty good job, meaning only 33 out of 240 some odd cases actually got embolization, even though they were non-vascular tumors. Were those tumors, was there any suggestion that those might have actually been more vascular on the imaging, or what do you think determined why those got embolized? And finally, any complications with embolization?
Yeah, all fantastic questions. I don't think we did any direct radiographic comparison to look at like T2 signal or degree of enhancement or degree of bony destruction. Though that's a great idea for a follow-up study. And then we didn't collect complications on embolization, but that would also be an important point in terms of risk-fit analysis or EMBO in these patients who, at least by our primary endpoint of blood loss, did not seem to benefit. All great thoughts.
One thing that I've noticed is, because I talked to the EMBO people about this, is if they think they're going to get a complication from cord perfusion, they will not embolize one or more of the vessels. And when embolize one or more of the vessels, then sometimes I think you get the bleeding because the remaining, say you have 3 segmental feeders, they embolize 2 of the 3, the one is still feeding, and then it still bleeds a bunch, but they're scared to take that last one because they think they might infarct the cord. So I think you don't see a lot of complications on the one hand because they're mitigating risk. And on the other hand, you're still seeing the blood loss even though you did the embo.
Question for Abraham. Nice presentation. You used MCID as your main marker. Now, the problem with MCID is you may still be completely dysfunctional even reaching MCID. So, if you start really bad and you hit your MCID, you still may be at bed rest or non-ambulatory. Why did you choose MCID, and did you think of maybe looking at other functional markers, perhaps if they're able to walk or able to ambulate or other markers?
Yeah, that's an excellent question. We used MCID for KPS, primarily just availability in the chart because we did the retrospective analysis of these patients. To your point, I think a lot of our patients did have a decent MCID at the start. And those who did not achieve MCID, they started with around 60, and those who did, they were around 40. So they still did have some to benefit from surgery, and we defined our MCID as a improvement in around 10 points, which could have a pretty impactful functional outcome for these patients. So we still thought it was worth investigating, but mostly just due to the availability of the variable.
Tally results and going out to winners.
Vivi will take some pictures for us. We'll start with third place.
Yeah.
Suspension. All right. Our third place winner for the abstract this year is Dr. Miles Hudson for the assessment of transitional slippage between upright X-rays and MRI, supine MRI. Come on stage. Yeah. Go on. Thanks. Take some pictures. Yeah. Vivi. All right. Yeah, great. And then the second place for this year is Dr. Alexa Samochi. So all these lays have money in them, so don't throw them away after you wear it. Our research coordinator spent hours this morning making them. So.
And for our winner, I am very proud to announce was Lisa Bonsignoriop for validation of the injury severity score in pediatric thoracolumbar trauma. And come on up, Lisa.
Yeah. Is the light on the? You should go down there.